Myself, Dr. Sharaj Bhattacharya from Tinsukia, Assam, the chief instructor of the course. On behalf of all the co-instructors, I welcome you all. My sincere thanks to the Chairman Scientific Committee, Dr. Lalit Verma, for including our course in the great scientific feast of our country. And lastly, my gratitude to all my co-instructors, most of them are my mentors, for giving consent to be part of the course. The adequate depth of the anterior chamber always a prerequisite for a successful phacoemulsification. Too deep or too shallow anterior chamber has always forced even the first-paced phacosurgeons to slow down and adopt some modification to negotiate the loss of operative comfort due to the change in the surgical space. Myopia, floppy iris, and vitrectomized eyes are few of the list of the cause of deep anterior chamber. Similarly, misdirected fluid syndrome, intraoperative hard eye, and hypermetropia top the list of shallowing of the anterior chamber. Here with us, we had a panel of experienced phacoemulsification surgeons who will deal with the subject through the video-assisted surgical training and interactive discussion. All the speakers will have 8 minutes of time, and after that we'll have a 5-minute discussion. May I now first call Dr. Deepak Bhuiya, Associate Professor, Guwahati Medical College. His topic is pathophysiology of abnormally deep anterior chamber.
Good afternoon, everybody, and welcome you all to the instruction course number 516. The topic here is actually pathophysiology of abnormality in the depth of anterior chamber in relation to phacosurgery. Now, why the topic is, actually, like when we start doing a surgery in the early days, we all remember that we come back and talk, man, every surgery feels different. But over a period of time, we see that we forget that and we start doing all the different grades of cataract nucleus extraction by phaco with the same setting. That means the level of comfort increases, but that's where, like it can put the surgeon in a difficult surgical situation if not prepared, leading to some complications. We all know about all these causes of deep anterior chamber and shallow anterior chamber, especially in reference to the preoperative shallowing of the anterior chamber is another important factor. Now, operative abnormal depth of the anterior chamber, we should be conscious about the causes like mechanical pressure by the speculum or the drape, leakage from the paracentesis or the main tunnel. There may be low inflow due to compression of the slip of the phaco-tip by a tight entry wound, and there may be fluid misdirection syndrome and suprachoroidal effusion or hemorrhage. Fluid misdirection syndrome is another very important point because at any level of the phacosurgery, even through the healthy zonules, the fluid may be directed to the vitreous, and there is a forward displacement of the lens iris diaphragm leading to a shallow intraoperative chamber. So just to remind that we can be conscious for the variation of the anterior chamber depth from the very beginning in the OPD, like from the history of VR surgery, trauma, connective tissue disorders, then refractive error status of the patient before surgery will give us idea about myopia, hypermetropia. A very small white to white diameter will give you indication about the non-ophthalmic eye. Then anterior chamber depth idea can be have from before the optical biometers, anterior segment OCTs. And then the most important that we should not forget that even in an eye of normal or longer axial length with a shallow anterior chamber should give you an impression of possibility of pseudo-exfoliation syndrome because of weak zonules, the lens iris diaphragm comes forward. Now, how should we be prepared to handle it? So I picked a few points like use of special OVDs during the surgery. Like whenever we handle a shallow anterior chamber, it's very difficult, like because of the convexity of the anterior lens capsule, there's running out of the rhexis. So there's a need for, like cohesive viscoelastic And to protect the endothelium, we should be ready with dispersive or whatever you call a soft cell technique or something like that. The question of using a cystitome or a rhexis forceps. Whoever is used to whatever it is doesn't matter much, but it's seen sometimes in a shallow anterior chamber. While using a rhexis forceps, there is a tendency of iris root prolapse. So sometimes you may have to shift from a rhexis forceps to a cystitome also. And then we'll be talking on the tunnel size and the location. The phaco tip, basically, this is the vector force or the direction. When we work on a deep anterior chamber, it will be better to use a band Kelman phaco tip, and always a bimanual irrigation aspiration is a better option. So the vector force inside the eye, like how the capsule is torn and how the phaco tip reaches the lens as the surgeon is working at different AC depths, simply changing the band of the cystitome, we can make it useful for a shallow chamber or a deep chamber. Now related to the tunnel size and location. We all know a square tunnel is the strongest tunnel. So for example, if we use a 2.8 phaco tip and use a square tunnel in the limbus, we are reaching almost half of the radius of the cornea. So when we go such a forward position and tilt the phaco tip for a deep anterior chamber, say in high myope, you can see the red line depression of the cornea, which will distort your field of vision because of the corneal fold. So it's better in case of a high myopic to go little posterior, which maybe we call it a posterior limbal incision, or maybe a little scleral with little bleed, doesn't matter much. But you go less farther into the cornea. Reverse is the situation for hyperopic eyes. In hyperopic eyes, we should do the incision location a little anterior limbic, because the posterior lip of the tunnel will protect the prolapse of the root of the iris in this situation. So we should also keep in mind about the reverse pupillary block. We all know while doing a phaco surgery in a high myope where the iris is compressed backward, the pressure rises, chamber deepens, and the pupil dilates. Simply manipulating the iris or the capsular bag with the second instrument can be handled. And I think it's very important to observe this situation at the end of the surgery, even after putting the IOL. When you finish the surgery, if the chamber is left too deep and the pupil dilated, there may be subsequently postoperative pressure rise. To handle the intraoperative shallow AC, we should first look into loosening the speculum or the drape, or look for retrobulbar hemorrhage. If there is a leakage from the main port or the side port, we can hydrate the port, or even we can put a suture. And if there is insufficient flow, we should keep in mind that our entry of the phaco tip into the main tunnel may be very tight. There may be compression of the sleeve, so little enlargement of the main tunnel will correct it. At the end of all these three small steps, even if there is a shallow chamber, I call it a finger test. You touch the globe a little bit and you feel it, that if it is hard, then you should not forget about fluid misdirection or choroidal effusion and hemorrhage. It's important to do an indirect ophthalmoscopy on the table to look into the retina. If the retina is normal periphery, then you should think about fluid misdirection. And if there is an elevated mass, of course, there is possibility of suprachoroidal hemorrhage and effusion. If there is fluid misdirection, that means the retina is normal, then we can do a vitreous tap with a 24 gauge needle, pass to the pars plana to the anterior mid-vitreous and aspirate the fluid mixed vitreous a little bit, 0.1 to 0.3 ml around, so that the anterior chamber gets an adequate depth to work. But in case of suprachoroidal effusion and hemorrhage, we'll have to defer the surgery, maybe from a day 1 to day 7 until it improves. So to recognize a potential problem at the earliest is very important. Then making a sound diagnosis intraoperative and managing the situation at that particular moment scientifically is important to reduce the possibility of complications. So being alert and adhering to the general principles of surgery, in abnormal AC depth conditions minimizes unfavorable outcome. So thank you very much. That's how I like to introduce the chapter, and subsequently the speakers will talk to you in details. Thank you.
Thank you, Dr. Swaraj, for having me here. It's lovely mid-afternoon or early afternoon, you can say. And nice to see all familiar faces from my state. I am still, though I work in Calcutta, I am by heart, by soul, an Okhomia. So I feel that I am back with my roots. Thank you. So I'll be speaking something on high myopia. Now, being in practice for 20 years, definitely, and shifting more towards refractive cataract surgery, other than the routine, high myopes coming in, and my partner, he is more of a refractive surgeon. He goes for any high myopia, goes for ICL, and I oppose ICL. I say I do refractive lens exchange, and he opposes me in every forum. Well, if you take real precautions, even in high myopes, because again, just a prelude to that, why RLE you can do if you have seen the retina, if you have seen the periphery, because then every person would be having retinal detachment, because we do it. I mean, we are doing high myop cataracts, but do they end up in retina? Because we take all those precautions. So RLE is an option if you have seen if you have got the right person. While high myopes, as 5 to 20% of these patients do have cataract, the issue is the maculopathy and the amblyopia. That's the first thing, is the patient amblyopic or anisometropia, and something else is maculopathy or high myopes. When you talk of high myopes, anything between 7 and 8, but we are looking at something like -12, -14, those patients. So the cataract can be just a nuclear or posterior subcapsular cataract, or in if the patient comes too late, it can be the heart cataract or whatever cataract may be. So when you see these patients, it's very important. You do a cycloplegic refraction, see the astigmatism is there or not, and look at the pupillary size. Most of the people would dilate very well, but there would be cases where dilatation is a problem. The cataract density under type, and many of these high myopes actually on table, especially the spherophakes, early spherophakes. You thought that this is absolutely high myope. The moment you take it in the OT, maybe it's dilating, mid-dilated, you are not seeing. The moment you put viscoelastic, make the anterior chamber dip, and you see it's basically a spherophakia grade 1 or something. So subluxated cataract or spherophakia can be a presenting symptom as a high myope. We have to be ready for that, and the AC depth and all becomes dip, and the scleral rigidity is less. Fundus examination, as I said, foveal contour or phobia you have to see, because you have to promise them a good result after surgery. Retinal periphery, you have to look for PVD or liquefaction of vitreous. Once you remove the cataract, the PVD symptoms should increase, so you have to counsel the patient. You can see more floaters, more dots, because whatever steps I will be saying, you would still would be inducing some sort of PVD, even if the PVD is not there in the high myope. So they would start complaining of floaters other than the dry eye symptoms. That would bother you more in these cases. So prophylactic retinopexy, I would do it, being a retina trained person. I see some retina guys also. If you think that you are not able to visualize the periphery well, take a help of your retina colleague, and definitely they can, even if you are can do some of the peripheral degeneration, but with the indirect ophthalmoscope, with the indirect laser, the retina surgeon can reach the periphery and give you that protection before going for these cases. Anything above 26 millimeter is definitely axial length risk. There is a danger of PVD, CME, compromised zonules, as I said, and other thing that Dr. Deepak Bhuiya just said, the retropupillary reverse pupillary block, that is what you might meet in your surgery. IL power calculation, we have a plethora of formula, but this is what I said today with the universal Barrett formula that covers most of the thing. In case you don't have it in your biometry, you can download it and fix in those values. You get near correct, or otherwise Haig's formula is supposed to be. But if you are still not, SRKT will give you reasonably good result. That's what has happened with most of us today with, going for RLEs and going for the advanced lenses. Probably we are using more of this universal Barrett formula. You need to spend some time with this when you do this. And the IOL choice, square edge, 360-degree square edge. We don't have 6 or 6.5 more than 6 millimeter lenses normally, except the Rayner lenses are probably 6.25, but the others are 6, but ideally would be around 6.5 millimeter lenses. So you have wider areas of coverage. The rexis size, as I said, little bit has been told by Dr. Swaraj about the head position, and I just said the head position, low microscope illumination. These are some things. How you sit in these patients is very important. And the surgical technique, basically all steps must be taken to minimize the instability of anterior chamber, thereby minimizing the anteroposterior movement of the lens zonal diaphragm. Phacoemulsification and the fluidics with a small incision are said to reduce forward movement of the vitreous. And this is where the advanced phacoemulsification machine like Centurion, I just no financial interest, probably that's the machine that would give you that fluidic balance where there's active fluidics. In these cases, normally you would keep the bottle height low and again bring the bottle height in a normal machine. These are the ways that you can see. Now about the surgery, well, I won't come to these steps. I'll just show 2-3 videos which will give us Now if you look at I was saying what the problems during phacoemulsification, this is a video, something I was not aware of, some 15-year-old video, which those or 18 years back, when I was not so aware what are the problems that I would face in a high myop. This actually implies, I show it in almost all the, see, look at the AC is becoming shallow. These are the problems that you can face. Now look at, this is a straight tip I am using in those days. See, I'm trying to go, look at the depth, the way the phaco handle is going down. So you're not getting the right hold, and the fluidics is not here. So every the occlusion is occurring as I'm trying to live. I'm trying to do all sorts of maneuver. Well, I managed to break the nucleus, but then see, every time I am trying to get that and the AC is becoming deep. This is, yes, there is the retropropulsion syndrome, but it's not happening that much. See, the iris has come out, the AC has become shallow again. And then again putting in a viscoelastic, basically tapping from the side port, getting the iris down can help you in these sort of cases. Look at this, get sight from the periphery, exactly, because you cannot chop it so well because the depth that is there, you have to go down, and that's the way you go down. And so just how to avoid the anterior chamber shallowing. Now this is the one that I would do presently, and once I've taken off the most of the, I can see the hydrodissection or hydrodelineation, the phaco part. Well, I'm trying to stay in the periphery, trying to do the cartwheel technique, but get it from the periphery, because if you're going to get it towards the center, because every time you take out your instrument, see that you push, make it, some surgeons have a habit of doing this maneuver, putting in viscoelastic every step you take out, but if you follow it in case of definitely in high myops, that's a big help. And just talking of the cartwheel technique in the softer cataract, because most of them are soft cataract. Just a minute, as you can see, the rexis, so get it, fold it from the side. So if you're trying to go in the center, probably it will become deep. You may not be able to, chop it. So go to the side, and this is the cartwheel technique where you get the periphery or mid periphery of the nucleus, rotate it, and it comes down and back to you. Just to continue with the presentation, a few more slides, I think. That's it. Yeah, post-operative assessment, well, do the cornea, do a regular checkup, see that the periphery is okay, periphery, if there is, whether even if these techniques, whatever method you have done, you might end up still with peripheral retinal breaks. And the yak capsulotomy, well, this again is high. Try to do a capsular polishing and try to clean the peripheral of the anterior rexis margin, the rim, so that the need for YAG is as much as delayed as possible, because the chances of retinal detachment is as high as 0.9 to 10%. There has been advocate of people who propose a primary posterior capsulorhexis, but I don't follow it. I don't know if anybody follows it. And there's the UVM picture, how the lens positions itself at the end of the surgery. And the risk of retinal detachment, as I said, is almost the spontaneous retinal 40 times than emmetrops in after phaco surgery. That's what one of the studies suggests. So this is one more. We can take risk of anterior posterior movement. That's the only way we can do it. Just reduce the risk by minimizing the anterior posterior movement of the lens or zonule. So using a better machine with a better fluidic control, so that you do not have any fluctuation. I would rather use a low the vacuum around 250, a normal machine around 300 instead of 400 and 450. Keep the bottle height around 90, and then lower flow rate. Make the surgery slower or lower, and always skip a side port with a viscoelastic, whichever steps you follow. Thank you for your patient hearing.
Thank you, Dr. Ajay. In this context, the high myopia, I think the iris rectopulsion syndrome should also be thought of sometimes.
Yeah, that's what I said. You do get it. I showed
Yeah,
it that you do get it, and this is something that one has to be aware of it. And the way to is just take a spatula from the side, just tap the iris down. That would get you.
Thank you so much. Now I call Dr. Shubhra Kinkar Goswami. Is the director, Nalbari Eye Hospital, Nalbari, Assam. He will talk on the intraoperative shallowing of the anterior chamber.
Thank you very much. Thanks for giving me a chance to share my experience with you. And Professor Bhuiya has made my job easier, because he has covered almost all my topics which I am supposed to tell. So the preoperative evaluation is very important. The anterior chamber depth should be carefully examined, and the slit lamp biomicroscope and the biometry has got very important role, because while doing biometry we can assess how much the IC depth is there, and accordingly we can prepare what we have to do during the surgery. A shallow anterior chamber can be seen in physiologically normal, but small eyes with short axial length, as well as even in small nanothermic eyes. And in these eyes, the lens calculation are best done with a Holaday 2 formula due to the anterior effective lens position, because it is coming out. So that's why Holaday 2 is the most effective corrective lens calculation formula, like that. So a shallow anterior chamber can be the result of pathologic process within the eye, such as glaucoma also. In narrow angle glaucoma, the anterior chamber is shallow due to the configuration of the anatomic angle. As cataract develops, the anterior position dimension of the human lens can increase. It pushes forward, so ultimately it crowding the angle. In this eyes, cataract surgery not only improves the vision, but it can also help to treat the glaucoma by opening the angles of the eye. Pseudoexfoliation usually we look after. Pseudoexfoliation is a disease process in which the zonule that is usually weak, and it allows the lens iris diaphragm to push iris forward, and ultimately it induces the shallow anterior chamber. Biometry of pseudoexfoliation eye that shows a normal, so long axial length but a short anterior chamber depth is a sign that the zonule will be particularly weak during the cataract surgery. See, this is the pseudoexfoliation. This is the small bubbles like this. So intraoperative management, with shallow anterior chamber performing a capsulorhexis at the beginning of the cataract surgery is difficult due to number one, poor maneuverability because it is very shallow, and lack of flattening of the anterior lens capsule. It is coming out, is just coming in forward. So definitely the maneuverability is difficult. In most situations, this can be addressed by injecting viscoelastic repeatedly at the time of surgery and during the surgeries. Cohesive viscoelastics do a better job of creating and maintaining the space. In rare cases, if the anterior chamber remains excessively shallow, a limited pars plana anterior vitrectomy can be done to remove the volume of the vitreous cavity. This allows the anterior chamber to be further deepened during the surgery but may pose additional risks to the retina. And that surgery, if you have a posterior segment surgeon with you, definitely you can do that on the same sitting. Otherwise, you may postpone the surgery for a few days. So therefore, the technique should be used cautiously. So let's see what we do with a shallow anterior chamber. The incision, usually I take clear corneal incision. I injected the viscoelastics. Then cohesive viscoelastic. Then making the main port also very, very difficult. Somehow I did the main port. Usually I use cystitome. But in that case, it looks like I may not be completing the rhexis with cystitome. Injected the viscoelastic, then tried with Utrata forceps. See, the capsule, anterior capsule is bulging out, so definitely there is a chance for capsule running out. Every step poses problem in shallow eyes. That's why I'm going to show all last this. See, now somehow I finished the rhexis, made a big rhexis. After hydrodissection, it becomes more shallow. Again, I injected the, all the time you have to be prepared that you have to consume at least 1 or 2 high molecular viscoelastic during this surgery. See, very difficult to insert the Phaco probe. We have to be very careful that you might hit the posterior capsule or you might hit the endothelium. So, keeping my Phaco probe at the center only. The most riskiest part of this, because this is the part where you might hit the posterior capsule. Now people got constricted. So again, implanting the lens, pushing it towards vitreous. So I am mentally prepared that I have to give the postoperatively cornea might be compromised, so somehow finish the surgery. Let's see this one. I finished the surgery. The first step I am just showing, and last stage I am just showing. Very difficult to make my main port. Usually two-step incision I do. See here I finish the surgery. Now the problem comes. The iris starts coming, trying to push it back. Eyes get harder and harder. Trying to push it back. It's not going. Everything becomes messy now. I don't know what to do. While I cannot make the incision bigger also, then I thought I should go with making another main incision to implant the lens. Sorry for the poor focus, because that time I was somehow, see, now I am just protecting the previous one, so surgery was over. So my take home message is that while you have the shallow eye, you must be prepared beforehand. You should not compromise with viscoelastic. Plenty of viscoelastic, particularly high molecular viscoelastics, must have with you. And patient should be properly counseled that he may, because you may require second setup, because you may have to go for postplantar vitrectomy also if it is, you cannot manage everything now. So thank you very much. Thanks for your patient hearing.
Thank you, Dr. Subhra Goswami. In this context, I'd like to add a single point. What I feel, when the iris is prolapsing out to the main wound, why not try with the side port? The reposit. Yeah. Anyhow, so let's come to the next topic by Dr. Avijit Hendik. He will talk on phaco nightmares with vitrectomized eyes. Now we have good number of audience. May I request Dr. Subhra Kinkar to come and help me? Deepak Bhuya sir, Professor Deepak Bhuya also. You also come.
Good afternoon, everyone, my teachers, my friends, and everyone here. So I feel honored to be a part of this instruction course. So my topic will be on phacoemulsification with vitrectomized eye. First of all, let's have a look how a post-vitrectomized eye differ from a normal cataract surgery. So whatever the indication of vitrectomy was there, the first thing we know that the vitreous which was there in a normal eye is removed after vitrectomy. So we don't have the vitreous cavity, anything apart from the air or gas with what we inject after the surgery, or the fluid or silicone oil. By the time we are ready for the cataract surgery in a full post-vitrectomized eye, inside it remains either aqueous or silicone oil, as because the gas or air whatever was injected beforehand will be replaced with the aqueous humor. So either we face aqueous or silicone oil inside. So with a eye with aqueous humor inside, whenever we put the irrigation on, look at the phacoemulsification, the lens iris diaphragm will be pushed backward. That's why in a post-vitrectomized eye, we find a abnormally deep anterior chamber and which is also fluctuating. This is because of the loss of the support from the vitreous cavity. Perhaps in the eye with the silicone oil fill, there is not much difference whenever we put the infusion on inside. It will just remain stable, it will be there. But we shall have to take care whenever we take out the infusion, because if there is a pressure gradient, if the pressure is not balanced, then the silicone oil will find a way to come as a small bubbles to the anterior chamber. Along with that, we shall have to also think about the additional pathology in this kind of complicated eyes, like scar or the buckle or the biometry issues. So in a post-vitrectomized eye, we shall have to encounter many situations, then we shall have to prepare our cases. So how do you go ahead with such a case? The first thing is to have a very thorough evaluation for expected eventuality. Just like under the slit lamp, if the visibility is good enough, the photo is courtesy American Academy of Ophthalmology. We may find an injured capsule which was injured during the vitrectomy. The lens touch does happen in vitrectomy. This is one of the issues everyone knows. And after that, if there may be a small capsular break which may also induce cataract. So if it is visible, we shall have to know that there is a capsular break, and we shall have to take proper precautions. There may be membrane over the lens, there may be fibrotic capsule, there may be zonular tears, and all these non-dilatic people. But the take-home thing is that we shall have to get prepared for expected eventualities. We shall have to get prepared, how to go ahead. We shall have to keep everything ready. While we find a deep and fluctuating anterior chamber, what's the strategy is to keep the infusion bottle low. We need a very low pressure in the anterior chamber, and simultaneously we shall have to go slow. How low and slow depends upon the surgeon's comfort level working in a fluctuating anterior chamber. But we shall have to really go low and slow in such a cases. If there is a iris retropulsion syndrome, like Dr. Ozeda has and others has also shown, then we shall have to just lift the iris with the iris spatula when still the irrigation is on. And once it is done, the iris will resume towards a little stable condition, and we can continue ahead with the phacoemulsification. In a silicone oil filled eye, as I have said, we won't find much difference in the anterior chamber fluctuation. But whenever we come out of the eye with the irrigation, we shall have to really keep the balance in between the anterior chamber and posterior chamber, such that the silicone oil doesn't peep into the anterior chamber. So if there are some iris issues like membrane or non-dilating pupil, so we shall have to take adequate measures like we would have taken in a regular cataract case with these complications. Sometimes we find a total cataract, which we find little intimidating, and sometimes, and this cataract may also have a pre-existing posterior rent, which we actually don't see. So there should not be any force or casual hydrodissection, even rotation also. We shall have to go ahead in such a case like we would do in a postopolar cataract, where we do a non-rotating phaco technique. This phaco technique starts with creating a small wedge at the distal end, then disengaging it and phacoemulsify it, then to go ahead to break the rest of the nucleus. Let us have a look at one of those cases with silicone oil filled eye. But the white thing we see is the emulsified silicone oil in the anterior chamber. We can remove it either by viscoelastics or by a simple fluid irrigation, whatever way you are comfortable. I am using here OVD, the simple SPMC, whatever we use in the routine cases. The rest is just simple. We shall have to do a capsulorhexis, but we may find little irregular glow because of the silicone oil inside. Hydrodissection, then rotation of the nucleus. Because this is a somewhat a soft cataract. In soft cataract, I always prefer to go for a horizontal phacoemulsification, horizontal chopping. So this horizontal chopping was initiated. Another piece being broken by horizontal chopping. So once it's being done, the things become really simple. We can emulsify it without any problem. You can see there is no fluctuation. Chamber depth seems to be very normal because it has silicone fill eye. But the thing I want to show that once I have decided to come out of the anterior chamber, we shall have to refill the anterior chamber with OVD. And pushing OVD through the left hand may be difficult if you are really not ambidextrous, and your assistant can help it in this situation. Here my assistant has pushed OVD, I'm just holding the needle, that's all. And this you can do in case of after just the IA also. You can see the silicone oils, the shining. Here I have come out, there are lots of flow. If I leave it, then some the silicone oil bubble will come. Then the similar way, I have refilled the anterior chamber. The lens implantation goes off as usual. We'll do a removal of this OVD as suggested. But at the end, we shall have to again ensure that the anterior chamber is quite tight and there is no leakage. Otherwise, in the post-operative situation also, at the moment we lift the eye, if there is a small leak also, the anterior chamber pressure will fall off and 1 or 2 silicone bubble will come into the anterior chamber. So the next day it may look bad, really bad. So the thing is that we can encounter cases like this, and this is what I wanted to convey. Thank you for your patient listening.
Thank you, Dr. Abhijit. He is the assistant professor in Asha Medical College, Dibrugarh. Now we call Dr. Biraj Jyoti Goswami. He is the director, Guwahati Eye Institute. For his talk, Basic Rules of Phacoemulsification in the Altered Chamber Depth.
Good afternoon to everyone on and off the dais. It's really a pleasure to be in a session where we are having all the OSA members. We had 2 sessions like that, and both the sessions were very enjoyable. I thank Dr. Swaraj for including me, and I have kept the title of the slide, my presentation, as the title of your instruction course, because that speaks the whole of my talk. Too much or too less, both can make a mess. Of course, my work is reduced by all the speakers because they have actually gone to the particular situations. I'll be going for the basic principles. I have learned from my mistakes that if I am forewarned, I usually make myself forearmed. So forewarned means forearmed, because particularly in phacoemulsification, because it is a 6-drop zone affair. If the anterior chamber capacity increases to 8 drops or 10 drops or more, or if it is reduced to 4 drops or less, in both the situations, we get problems many in cataract surgery, but both can be presumed in a lot of cases. We can plan forward to ensure a smooth procedure with good outcome. So when can we presume? Suppose a patient has come with high hyperopia or non-ophthalmos or very old patient or use of alpha agonist, we can presume that we will be having either a purposefully shallow chamber or repeatedly shallowing of the anterior chamber, what Subro has already shown. And if the patient has come with high myopia or horizontal corneal diameter more than 13, axial length more than 25, or post vitrectomy, we can definitely presume that we will be having a deep chamber. But sometimes, of course, it blooms without any premonition. So Subro has already gone through it. So, fluid imbalance and fluid insufficiency is the main cause of repeated shallowing of anterior chamber, with a very important 4P factor, that is preoperative positive posterior pressure with a tight speculum, that is the minor thing, or a little bit more major thing, fluid misdirection syndrome, and even a bigger thing, that is suprachoroidal effusion or hemorrhage. Similarly, sudden deepening of anterior chamber can happen due to a posterior capsular rupture with nucleus drop, or a zonular dehiscence, or IFIS, what Dr. Swaraj will deal with. We have to ponder before we touch, and ponder about biometry, ponder about anesthesia of choice, and ponder about the preoperative spatial medication like IV mannitol or like that. Particularly in biometry, what we used to have earlier days, SRK1, SRK2, SRKT, or holiday, we were considering two factors, that is axial length and keratometry. Later on, Haggis came with axial length keratometry with anterior chamber depth, and the modern day formulations like Barrett Universal 2 or Holiday 2, it has come with axial length, with keratometry, with anterior chamber depth, and with lens thickness, which can give us a very good approximation of the effective lens position beforehand. So, preparing as per premonition, if we have the premonition, anterior chamber depth, if it is 1.5 to 2 millimeter, we have to go by some steps like preoperative mannitol, use of super pinky or digital pressure. We have to position the patient because the hyperextended neck will increase the vitreous pressure, and we have to repeatedly adjust the speculum to see if we get any effect or not. Our incision should be anterior limbal and it should be little bit longer. Repeatedly use of dispersive and cohesive OVD to make a soft cell, and particularly every time we come out and every time we go in, it should be OVD should be liberally used, and bottle height should be adjusted either normal or raised. In anterior chamber depth, even lesser than that. All these 6 steps plus I go for a 25 gauge pars plana vitrectomy without irrigation, a very limited pars plana anterior vitrectomy. It immediately gives a deeper chamber. Our main principle is to reduce the vitreous volume and to protect the both end, that is the corneal endothelium on one side and posterior capsule on the other. But we have to remember when we are repeatedly using the viscoelastic that overinflation may be equally dangerous to collapse of the eye. Like here I have, where is this cursor? Yes. Like here we can see, no, we cannot see. Sorry, I just wanted to show that in hypermetrops I go to the anterior limbal incision, unlike the myopes where we go posterior limbal incision. Capsular axis, I go little bit smaller than my usual stuff because in most of the situations, challenge of cataract surgery, except in supra-hard cataract, I go a little bit smaller because we may end up in placing the lens in the sulcus. In that case, a good anterior capsular support is required. Then bottle height is adjusted as Abhijit has said. We should start with a 60 or 50 when we go in myopia, in deep chamber, and 110 for cello. Then later on we will adjust as per requirement. Hydro procedure should be small, repetitive, and complete hydro dissection, but we have to keep on the rocking the nucleus continuously. Here, I must, sorry. Anyway, here I'll take 1 more minute, Swaraj. We do not have the hall to give to anybody else. So here there are 2 situations. One, we have got deep chamber. One, we have got shallow chamber. In shallow chamber, the bottle height and on entry, bottle height should be 110, and in deep chamber on entry it should be 50 to 60. As I said, we will adjust later on, but we have to ensure that irrigation is sufficient. But at the same time, we have to ensure one thing, that this irrigation fluid has got all the propensity to move in between the anterior capsule and peripheral iris, causing a repeated ballooning of the iris. So whenever we are doing, we are pushing the irrigation, before that we have to, particularly in irrigation aspiration, we have to keep on pushing some viscoelastic at the equatorial area to plaster the anterior capsule on the back side of the iris, so that peripheral movement of the fluid is not there. Otherwise our life will be hell. So I prefer a slow motion, as Dr. Avijit has said, but we have to give a proportionate AFR as per the irrigation. We have to make the flow rate. Epinucleus removal is better done with a viscodissection, and as I said, IA can become tricky in both the situation. Also, a separate anterior chamber maintainer, particularly in shallow AC, and pushing viscoelastic to the equator repeatedly is a better choice. Yes, a thorough policy is very important, particularly in high myopia. We do not want to go for anti-arc capsulotomy. If we want to prevent it, then we should better. And Dr. Avijit, I will just replenish your thing, that post-vitrectomy cases are very notorious for two things. One is posterior capsular plaque and one is anterior capsular fibrosis. In both the situations, we have to be very careful. In myopes, of course, 6 millimeter optic size is more preferred, but definitely not a silicone IOL, because that person may have a vitreoretinal surgery in future with a silicone oil implantation. So hurdles are too many, but with the modern day knowledge, improved knowledge of the armamentarium and improved sophistications in our armamentarium, where is the challenge? We do not have the challenge. All we need is a prepared mind to plan and practice with patience and perseverance for performing to perfection. Thank you so much.
So now Dr. Saraj Bhatta from Tinsukia is the director of Lakshmi Eye Care Center, and he is talking on IFIS, how to deal.
So my topic is intraoperative floppy iris syndrome, how to deal with. No financial interest, of course. What is IFIS? This syndrome was identified in 2004 and published in April 2005 in JCRS by Dr. David Chang and Dr. John Campbell. It is specially associated with tamsulosin, Flomax, the most commonly used drug for BPH, but has been reported to occur with other similar drugs also. There is a tendency for the poor pupil dilatation, and the triad of the intraoperative signs includes the billowing of the flaccid iris trauma, a propensity of the iris polyps towards the phaco and the side port incision, and progressive intraoperative pupil constriction. The most commonly seen complications are the iris trauma, posterior capsular tear, and vitreous loss. What is the pharmacology? It's alpha-1 blockers are used for BPH and to treat urinary retention in women. And tamsulosin is an alpha-1A specific blocker, which is the identical receptor found in the dilator muscle of the iris. Even the short-term use can lead to the non-reversible iris dilatation, dysfunction in some of the patient. The incidence of the syndrome is 33 to 78%. Not only tamsulosin, some other like terazosin, alfuzosin, and doxazosin are also may cause IFIS. Do not overlook the woman for the floppy iris syndrome, as this may be prescribed for bladder problem and hypertension. Now, why Flomax? It relaxes the smooth muscles of the bladder neck, which is a mechanism of action for the treating BPH, and this acts on the iris dilator as well. And this blockade of this receptor subtype make the conventional dilator drops inactive. Now what's the management strategy? Proper history taking is very, very important. Past or present use of any alpha-1 blocker to be noted before planning the surgery, which leads to an uneventful surgery versus the surgery associated with significant morbidity and expenses. The respective study in the 2005 shows significantly greater complication rate than the control, and vitreous loss is as high as 70%, whereas landmark study shows in 2007 prior knowledge of the patient drug significantly reduced the risk of complication due to proper planning and timely intervention. This is a nightmare in my life. I have done the first IFS because in Hutchinson you have read one mind doesn't know, eyes cannot see, and I cannot diagnose this previously, and this was a nightmare. There was bellowing of iris, iris trauma, PC rupture, everything possible in one of my cases, at least it's 10, 12 years back. Will stopping the Flomax help? Once used, effects of Flomax can be for years even after discontinuation. No anatomical change to the iris muscle architecture. Stopping up to 8 weeks prior to surgery has got a limited success, but the results are unpredictable. So this strategy is not at all recommended. So what are the flag signs? Post-mediatic people of less than 6 millimeters associated with development of severe IFS, and clinical observation shows that if one eye has got floppy iris, there is a chance to develop in the other eye also. What are the preoperative prophylaxis? The treatment lays down is the preventive aspect. Atropine 1% 3 times a day, starting 1 to 3 days before the surgery, has met with a limited success. Intracameral adrenaline with a dilution of 1:1000, further diluted with 1:3 with BSS to yield a concentration of 1:4000, and which is used for improving the iris tone with great success. Different intraoperative technique that is employed, like well-constructed corneal incision, trypan blue, low fluidics, ophthalmic viscosurgical device, and mechanically pupil expansion devices. The corneal incision, long corneal incision is preferred, which prevents iris prolapse. Intracapsule staining by the trypan blue, it helps us to see the areas. One important thing they are saying that recent study shows that the use of trypan blue and its subsequent exposure to light for 1 minute actually makes the capsule tougher and hence less susceptible to tearing. Little doubtful, of course. Then low fluidics, reducing the fluidic parameter on the phaco machine by 10 to 15%, and the newer machines have come up with the adjustment like Centurion where you can do IFIS very comfortably. Ophthalmic viscosurgical device like cohesive OVD Hilon 5, Archinov soft shell technique. In very hard cases, we can go for Discovix with a combination of hyaluronic acid and chondroitin sulfate. Now, mechanically pupil expansion device may be iris retractor or pupil expansion ring, which mechanically dilate the pupil, prevent it from constricting and restrain the iris from prolapsing. Now we'll come to the iris hook. It's used in case of the poor dilatation to be arranged in a diamond configuration for the greatest effectiveness. It is important to make in a mind in cases when we have seen that the case is of IFI, maybe a pending IFIs, we should put an iris hook or other expander. I'd like to share a small video. थोड़ा help करिए. 65 years old patient using tamsulosin. Iris week is being planned. We are introducing iris week one by one, making the pupil hexagonal using the trypan blue, longer corneal tunnel, this is a hard cataract. We are going for direct chop. IVL is introduced, and gradually, very carefully, the iris hooks are being removed. This is another case where a 62 years old HP cases of patient of hypertension your patient is being used for temsoleucine for BHP, and add on the patient has got an exfoliation. In this case also, while putting the iris hooks, we must be little more careful. Putting the visco underneath the iris, this case has got a pseudo exfoliation, mind you. And then rexis tunnel and so on. Different pupil expansion ring like Milligan ring can also be used. And recently I am using this BHEX ring developed by one of our friends Shubhen Bhattacharya from Kolkata. This is a very excellent. This is the case I like to show you. "60-year-old male person. Here again the trypan blue is being introduced, long corneal tunnel, BHEX pupil expander. Device is snugged into the 2.2 millimeter incision and gradually pulled out. Now it has got the 4 flanks. Flanks with the holes are being introduced below the iris. And ultimately we are getting a beautiful hexagonal pupil where we can do our job very comfortably. This was designed for a multi-piece IOL. After the IOL insertion, flanks are very slowly released one by one. We must take care in this position to put visco in a wide way. And this. Now in the summary, the significant risk of cataract surgery can be avoided by proper history taking. Special planning and device can usually allow the surgery to proceed successfully. Education and interaction among the ophthalmologist, prescribing doctors and the patient about the IFIs helps a lot. So fire rescue team must always be ready. These are the references, and thank you for a patient hearing.
Thank you, Dr. Saras. It's wonderfully explained IFIs and how to manage.
Suraj, please. Have you ever heard of using pilocarpine just before the surgery in IFIs?
Yes, there are that I have missed out.
It increases the tone.
Yeah.
And by the time it really works to as a myotic, by the time your surgery is over. So it improves the tone immediately, but meiosis occurs after 7 to 8 minutes. By the time your surgical part is almost over.
At what point of time we are using pilocarpine?
Just before the surgery, 1 drop.
And within 7 to 8 minutes you are completing the surgery.
It usually takes that much time only. 6.
Take home message may not be good.
No, that is a there is a study. That's what I do. I don't
please,
do.
please.
That is a different issue. Another thing.
cannot do
Nowadays, the preferred practice for IFIs is to give a pentagon or hexagon, not a diamond. I mean, these iris hooks.
5 hooks are being used.
5 hooks are being used. One at the incision. On the side of the incision.
That prevents the chafing of the iris while putting the phaco.
Yes, chafing of the iris is prevented by giving a 5 pentagon. And about Subhra talk, I would like to say one thing. And if we go if we get a problem like that, repeated iris prolapse, the only single most effective thing, I mean, two parts are there. One, inject viscoelastic, whatever stage you are, underneath the capsular flap. You have to float the anterior capsule anteriorly to reduce the peripheral movement of the fluid. Number 2, one PI is very helpful. Am I correct, sir? Sir, one peripheral iridectomy at that stage is very helpful because posterior pressure is not there. All the time there is a communication, so the repeated bellowing will not be there. And Dr. Abhijit, please be careful again about the anterior capsular fibrosis, which is very common in post-vitrectomy surgery. Thank you so much. Posterior capsular plaque is very common. And in many times we get a posterior capsular rupture actually, pre-existing posterior capsular rupture, inadvertent touch of the myringotomy knife or some vitrectomy instrument on the posterior capsule, which gets fibrosed. It looks like a plaque. Actually, it is a rupture, pre-existing rupture. So we have to go for a slow motion. He has nicely said, considering that it is a pre-existing rupture.
Can I ask one question?
Yes.
So how many of y'all are doing a plan for a preoperative peripheral iodectomy in case of shallow AC? Do you all do it?
I usually do it. Iodotomy. No, yak PI I don't do much, but I do an iodectomy on the table. Yes, there is no harm. There is no harm, because these patients are also very prone to develop acute congestive glaucoma in future. Yes, Abhijit.
Like you have reminded about the fibrosis of the anterior capsule. This is a quite known complication in a post-vitrectomized eye.
Yes.
Even though when it is even more common when there is a emulsified silicone oil in the anterior chamber. And in these cases, the normal rexis sometimes is impossible. You shall have to cut it into the multiple plane and just make a capsular opening. And we shouldn't get worried much about extension of the capsulotomy opening. It's not a rexis, because the capsule is so much fibrous that you can comfortably do a phacoemulsification.
Comfortably you can do. Yes.
Sir.
But you can do a irregular opening also with.
I like
Yes.
to have a
Scissors.
comment from our H.K. Chaudhary sir about the instruction course overall.
I was just trying to ask
Yes.
what is that other instrument you are using while putting the B-hex?
Now B-hex ring,
Another special instrument?
this is the ring, and there is a
Only a
dilator
lister.
type instrument is there, dialer type instrument there, supplied by Surgical with the strip. Yeah, that
Lis-
was I was trying, but
If
I feel better with doing with the 23
Lister.
gauge forceps.
Lister is also fine.
Yeah.
Lister is fine.
I congratulate all the speakers. I think it was a wonderfully planned instruction course, very practical oriented. So Saurabh and Swaraj and the entire team deserves congratulations.
So how do you go for this in post-vitrectomized or high myopic patients? What is your parameters, sir?
No, I think as you said, you enter in a careful way and then plan once you are inside. I think there should not be a predetermined level. You should determine in every case based on on the ground reality at the patient.
Sir, have you done any vitreous tap earlier? Because it was
No,
done earlier.
I
Vitreous
have not.
tap
I have not.
in a
I have
very
not.
shallow chamber.
About shallow chamber iris coming out, I think sometimes, as you were telling, I think pushing more viscoelastic causes more harm
More
sometimes because
danger.
invariably it goes behind the eye.
Yes,
So
overinflation is
at
needed.
times we find through the side port, you rather bring out more, you deliver more visco from inside the SE, and then iris probably instead of pushing the iris and injuring it, from side port you let some vitreous out and then allow the iris go by itself inside.
At
I think that is less traumatizing
Then you can inject on the prolapse.
on the surface.
the
And
whole
that of course must
the
be,
whole
must
idea
be Hilon, not methylcellulose.
the
By all means.
whole idea should be make the iris plano, not a concave one.
Yeah. Yes. Thank you.
So thank you everybody, all the speakers as well as the audience. At least the last but not the last. It was a successful one. Thank you everybody.
They should be congratulated for being so loyal to the conference, staying till the last.